I'm Dr. Kwam Mackenzie, the CEO of Wellesley Institute. Welcome to Advance 2021, Building the New Normal. Before we begin, we wish to acknowledge the land on which the Wellesley Institute operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still a home to many Indigenous people, and we are grateful to have the opportunity to work on this land. Now, I'm pleased to welcome you to Advance 2021, Wellesley Institute's biannual Health Equity Symposium, and know that some of you will have joined us in person 2 years ago for Advance 2019, along with 150 local and international academics, policymakers, city builders, and problem solvers. Of course, things were much different then, and we are now living through a pandemic that has changed the way we live, work, and connect. We've seen rises in evictions, job loss, and homelessness. We've seen low income, essential workers put in harm's way so that many others could stay at home and stay safe. And we've seen our underfunded health systems and long-term care homes struggle. And while COVID has been a story of health, housing, and employment, it's foremost a story of inequity. The gap between rich and poor has increased. Older people have borne the brunt of deaths. Women and younger people have been the hardest hit by the mental health impacts, and racialized populations have had up to 5 times the infection rates and death rates from COVID-19. Now, many will tell you that the pandemic has shone a spotlight on historic and systemic inequalities, but we say that we want to take it further. We say that the pandemic has challenged us to rethink our priorities. And that's what we're going to be exploring over the next 4 weeks of our symposium series. How we prioritize equity when we're building a new normal. I'm glad that today we're going to start the discussion on how COVID differentially impacted certain communities, but also what can be done about it. Now, before I introduce the panelists, I'd like to go through a few housekeeping notes for today. Now, we're going to start with me introducing the panelists, then have the panelists' presentations. Then we're going to come back together for a discussion afterwards. And I'd like to thank everybody who submitted questions for our panelists through the events webpage. But if you haven't, you can feel free to still submit a question through the Q&A function on Zoom. Now, I'd like to introduce our panelists. We have 3 remarkable panelists that we will hear from today. And they're going to present in alphabetical order, and so I'll say who they are in alphabetical order. First, we have Dr. Carole Estabrooks joining us from Edmonton, Alberta. Now, Dr. Carole Estabrooks is Dr. Carole Estabrooks is a health service researcher and holds a Canada Research Chair in knowledge translation in the care of older adults in residential long-term care settings. She studies the influence of organizations on the use of knowledge and its effects on quality of care, quality of life, quality of end of life, and quality of work-life outcomes. She has been the recipient of several awards and distinction, amongst them the Order of Canada in 2016. She is a Fellow of the Royal Society of Canada, the Canadian Academy of Health Sciences, the American Academy of Nurses, and the Canadian Academy of Nurseries. Welcome, Dr. Estabrooks. Second, Carole Hopkins, joining us from Bothwell, Ontario. Carole Hopkins is the Chief Executive Officer of Thunderbird Partnership Foundation, which is a division of the National Native Addictions Partnership Foundation. and she is of the Lenape Nation at Moravian Town in Ontario. I hoped I'd get that right, Moravian Town. She has spent more than 25 years in the field of First Nations substance use and mental health. She has co-chaired many national initiatives, including one that resulted in the landmark First Nations Mental Wellness Continuum Framework. She was appointed as an officer in the Order of Canada in 2018, and in 2019, she was recognized with an honorary Doctor of Laws degree from Western University. Welcome, Carole Hopkins. And third, Angela Robertson, joining us here from Toronto. Angela is the Executive Director of Parkdale Queen West Community Health Centre. She is one of the most effective people in developing equitable health services for low-income and racialized people that I know. For instance, in response to the impact of COVID-19 and pandemic on racialized and low-income populations, Angela initiated a raft of actions which led to the collection and use of sociodemographic data, the development of a more equitable vaccination strategy, and implementation of a number of effective cross-sector partnerships which decreased inequities. Angela has been recognized for her social justice work by many organizations, including the Fred Victor Center, the Urban Alliance on Race Relations, and she was also recognized by York University with an honorary doctorate in laws degree for her social justice work. So you can see that we have got an awesome panel, and without further ado, I'd like to move on to the panel presentations, starting with Dr. Carole Estabrooks.
I'm just going to share my screen, hope that it works. I'm always so grateful when technology works. Thank you very much for the lovely invitation, and thank you very much for everybody who's taken the time to attend today. I'm going to talk very briefly from the perspective of residential long-term care and the impact that COVID has had on there, and some of the ways that we're trying to emerge from the impact in long-term care. As we've heard, and you've heard for many months and will continue to hear, COVID had its impact, not because it happened out of the blue into a system that was functioning well, but because it happened out of the blue into a system that had deep structural and systemic problems and weaknesses that we'll talk a little bit about here. These are the sober facts. We've all seen them. We've had almost 30,000 deaths in Canada. In the first wave, well, I'll come to that in a minute, and we've had about 5 million deaths globally. COVID-19 pales in comparison to some of the great scourges historically that have struck the earth. 50 million died in the Spanish flu, 35 million have died from HIV/AIDS thus far, approximately. And of course, in the 13th, 14th, and 15th centuries, the Black Death or bubonic plague took upwards of 200 million lives. So it's an infant by comparison, but nonetheless, in the last 100 years, and given the state of civilization's progress, it's had a devastating impact, and one that we're, of course, as we all know, going to feel for decades and decades and decades to come. In long-term care, well, first of all, I never thought I'd see the images I saw in long-term care or elsewhere in the world. They've really certainly shattered my sense of safety in the world, and certainly shattered the sense of many other people less fortunate than I. Canada is in an unfortunate position of having the worst performance internationally on the globe of deaths in long-term care as a result of COVID. In the early phases in 2020, 80% of Canadian deaths were in long-term care. It still approaches 70%. This is in a country with an extraordinarily high quality of living, a high income country, and a country that's seen by many people as a desirable destination for immigration. So the questions remain: how could we possibly have done this poorly, and how can we remediate, and how can we remove ourselves from what can only be described as an international shame? There's no other way to describe it. There are lots of reasons for it, and I'll talk super briefly about those, but we'll also talk about some of the solutions. The most emblematic image for me out of COVID-19 in 2020 was the woman who was not allowed to see her parent, whose parent was dying in long-term care from COVID, who got an arborist to bring a tree cutting truck thing and crank her up to the third floor so that she could look through a window. The second image that burned in my memory was the image of the Canadian military being brought into nursing homes in Ontario and Quebec. And of course, we've now experienced some of this in Alberta. If the military's been called, you're way past bad. And the fact that we could let it get that bad is just, it's disturbing in very deep ways in Canada. COVID-19 killed a lot of people, and it killed a lot of older adults. But the conditions of COVID are something that we're just beginning to hear about, and we'll hear about increasingly. This is a very good report in the Washington Post over a 6-month period, 2020, that showed the expected deaths from Alzheimer's and other age-related dementias. And then it showed, they calculated using CDC data, the excess deaths. So there were about 13,000 more deaths than they would have predicted from Alzheimer's and dementia. So those people, yes, they had Alzheimer's and dementia, but they were community living. And what they died of was the conditions of COVID, primarily isolation and loneliness. That is the tiniest tip of the most incredibly large iceberg that we're just beginning to unpeel. And we will hear more and more about it. And many of these deaths will never be, most of them will never be recorded and attributed to COVID, but they're there, and we should remember that. Long-term care is, I think of it sometimes as a crucible. So all the things that you've heard about in the scientific literature, in the popular media, that you'll hear about from the other panelists and from your friends and your neighbors, and you've experienced yourselves, it all comes home in long-term care. It's like a container that brings all of life to the end of life. We tend to homogenize long-term care, and once you get the label old, there's a kind of an immediate homogenization that goes on, and we whitewash it in this, well, it's just old people. Well, yes, it is very old people these days in long-term care, but they bring with them their race, their culture, their ethnicity, their sex, their gender identity, their previous history of mental health and substance abuse, their history of psychological trauma, their history, everything that happens to us in life comes with you. It's not as if it all disappears when you get to long-term care. And we have not done a very good job historically in long-term care of recognizing and addressing and trying to meet the needs of older adults in these positions. I'm doing some work right now with older adults with advanced dementia in long-term care who have histories of psychological trauma, and they get treated as if they're challenging behaviors of dementia when in fact they're PTSD. And you can't just talk to someone with advanced dementia and fix anything. Not that talk is often the way to fix some of these things, but there are things that we know from science, neurobiology now, that we can do. And that's just one example of the things that come home to rest in long-term care. So I have, before COVID, I used this slide quite a bit, and I said, we have a building perfect storm happening. We have rising resident needs, and rising, why would they be rising? We're older, there's much higher levels of dementia. 80% of people have some form of a dementia in long-term care. And some people would put that number really higher. They're coming later in the phases of their dementia, so they have a more advanced communication and other challenges. These are incredibly complex people to care for and try to provide quality of life for. They also come with multiple chronic conditions. They come with all the things that I've just mentioned, and they come with high dependency needs. Often you get to long-term care because your needs can no longer be met by the family or extended family or friends or the community. looking after and caring for people who have that profile is incredibly complex, sophisticated work. We have in Canada and elsewhere in high-income countries relegated it to the work of caregiving, to women's work. It's how hard can it be? It's just helping older people at the end of life eat and be clean, and that is so wrong. But because we have these attitudes about older adults and the work of caregiving, which is highly gendered, we then think it's okay to, what we've done is the best you can say about the workforce is we kept it flat, but in fact, we lowered the capacity in the workforce by thinning out the skill mix, by not providing across the country adequate education or continuing education, by thinking that it was okay to not provide full-time work, to not have pensions and benefits, and the host of things you've begun to hear about this workforce. This workforce is highly racialized. It's over 95% women. They tend to be older. Most of them have high school, and most of them in some provinces have some kind of vocational training. Prior to the pandemic, we weren't tracking who was working where. We were tracking a small cohort of homes in the West, and we knew that about a third of care aides or PSW we began to realize what a catastrophe that one little thing was. Well, it's not a little thing. So this is a workforce that has, just like the residents, they have multiple stacking vulnerabilities, and you keep stacking them, and we all understand what happens. And then you put the two together and you get a really critical situation. And then COVID came, a novel virus with no cure or treatment really, except supportive measures. We didn't know how it spread. And it happened in a system that was physically structurally unsound in terms of the way the buildings are built. They're old. Some of them were built in the 60s. And happening in a population who had an aging immune system that couldn't combat the virus as well as younger adults. And so what we saw was not surprising. Why we saw it to such an extensive level in Canada is we understand some of it, but it's much more troubling than it appears on the surface. I had the privilege of chairing this Royal Society task force working group last year, and we were the first report that they produced on a series of populations that COVID-19 was affecting. We made a lot of recommendations, but we couldn't boil the ocean. We got into that conundrum, and we sat down and had a heart-to-heart one day and said, if nothing else, if there was only one thing in this country that governments and regions and jurisdictions did to fix this, what would it be? And it was very clear that it was address the complex workforce issues. So we went hard on the workforce issues. We did the best we could given the crazy timeline we had, to also, because we felt it was an opportunity to outline the historical and systemic problems in long-term care. I mean, this is a sector that had its history in 17th century Elizabethan poor law that created different classes of the poor, and nursing homes have kind of created different classes of the old. The people with great wealth do not experience the kind of things that you're reading about in nursing homes because they don't go to nursing homes. But that is out of the reach of the vast majority of people. But even high middle income people, it really is populated predominantly by women residents, older adults who are women, who have dementia, who have lower income. So that you can't even hardly get into a nursing home if you aren't old, you aren't a woman, and you don't have dementia. So before you even get in the door, you have three vulnerabilities, and then you stack on these other things. So what is needed? And what are we doing? Well, what is needed is absolutely a root and branch overhaul. Will that happen? Unclear. One might be, if your glass is half full every morning, cautiously optimistic, but practically this may not happen. But this is certainly the window, and those of us in this long-term care area, whatever part of it we're coming from, are really working hard to, because we know the window will close. Other things will come and fill the space. What we are seeing are the development of national standards, and I'm also a part of that. That's in process, and it really is, and I'm a skeptic at heart, an impressive process. However, even if they're the best standards in the whole world, they're not a panacea. They are one part to a series of solutions. We're fraught with federal, provincial, jurisdictional squabbling and fighting, partly, but not entirely, because long-term care is not part of the Canada Health Act. It's entirely provincial jurisdiction. The federal government makes transfer payments. I mean, you've heard it all. And it's getting in the way of addressing issues in a cooperative way in this sector. We called for a moratorium in our report on more reports. Over the last 50 years, there have been about 80 in Canada for adverse events, catastrophes, crises, the terrible fire in Quebec, and just a host of other things. They all get written, they're all good reports, and they all say basically the same thing, and nothing changes. One or two things are done, the political atmosphere changes, and the media moves on. I will say a side note about the media. They have done yeoman's duty during COVID in support of long-term care. I've been very impressed with them. But anyway, nonetheless, reports are being done, reviews, and some were already scheduled, and some were specifically about COVID, expert panels. Some of the responses in one or two provinces are very strong and they look hopeful. Others, it's unclear. So we've repeated history once again there. There's some work at raising minimum hours. They're atrociously low for this population across the country, and they have been forever. And we'll see what happens, but it costs money. Now, there is enough money in the system to work properly with most of our sectors, but it's how it's distributed. So we'll see what happens with minimum hours of care. There are attempts at workforce stabilization, but some of them aren't. Like just importing 10,000 people from another country and plopping them into a system and thinking that's a solution. Sometimes we do things in emergencies and then we see the unintended consequences play out. But we have to be very thoughtful because long-term care and the workforce and labor supply and demand are globalized. They're not local anymore. So we have to be very thoughtful when we're looking at immigration as a solution. And then we're beginning to hear concerns about mental health of the workforce, resilience and well-being. We don't know, the sector doesn't know what to do. And I would submit that we have little appreciation in Canada yet for how profound the mental health sequelae are going to be from not just the long-term care workforce and what they went through. We've been interviewing them, and it's a workforce in pain, but from the acute care side and from all the other sectors that have been affected. We know that a proportion of the workers, the frontline workers, are screening positive for symptoms of PTSD, and that just doesn't go away tomorrow or when COVID's over, if it ever is. For some of those people, those effects will last for decades. So there's a lot to be done. It's a mixed bag of what we have done. And hopefully in the panel, we can talk about some of the other things that we can do and where we might find points of pressure that help. Thank you very much for giving me the opportunity to do this. And I think I'm reasonably okay with the time I've used. Thanks.
Thank you, Carole. And now we move to Carole Hopkins. And I'm really looking forward to hearing what you have to say, Carole.
Okay, let me just find my way to share the slides with you. Okay. I am not sure if you're seeing the slides or not.
It says you started screen sharing, but I can't see your slides just at the moment.
Yeah, I am not either. And Somehow my system is locked, and when I'm pressing the right buttons, it's not doing anything.
Okay.
So I'm just going to
So-
talk.
Okay.
Never mind the slides.
Okay. If
Oh,
you're-
wait. It just, I think it started. Okay, I think we've got it.
Yes, we're good.
Okay, here we go. Okay, thank you, Carole, for that presentation. I think I have a lot of similar messages, and so I'm talking about First Nations mental wellness and the pandemic, and we know that substance misuse, anxiety, depression, the presence of intergenerational trauma have all been exacerbated throughout the pandemic. And we've seen also gaps in services, a lack of resources being highlighted, but there's also innovations that we've seen from First Nations. I want to situate this within policy and within First Nations rights. So there are some unique policy challenges that we have to be aware of when we're thinking about what the impacts have been in the context of the pandemic. So it's a dynamic, complex policy environment because there are very acute needs across the country prior to the pandemic that were exacerbated during the pandemic. Oftentimes policy is created, and of course we want expertise to inform policy, but unfortunately there's often a lack of engagement of First Nations people because they're not considered experts. And then there's comprehensive policy response to manage what changes are unique to First Nations people and drive innovation. However, those policy responses are problem specific. They're focused on one aspect and do not consider the environment or the determinants of health. So the policy response is short-term, limited, doesn't address the acute needs. And then the reality is that we have a lack of understanding between worldviews. I'm trying to figure out how to change that slide. Okay, there we go. This is all situated with, and I'm not going to go through a big history lesson, but you have to understand the jurisdictional differences specific to First Nations, Inuit, Métis peoples in Canada. What set the foundation of relationships are the treaties. We had our own worldview of how we understood relationships and how we understood the meaning of the treaties, and those are represented through a number of cultural, spiritual representation in our scrolls and our wampum belts. Again, they have spiritual significance. That's the foundation of a worldview of First Nations, Inuit, Métis peoples. Carry that forward to the patriation of the Constitution and Charter that articulated a promise of the recognition of First Nations jurisdiction, and recognizing the Constitution is supreme to other laws such as the Indian Act. But Canada is a member of the United Nations Commission for the Elimination of Racial Discrimination. And consistently we see progress, but we also see criticism by the Commission for Elimination of Racial Discrimination. In 2006, criticized Canada for minimizing the Charter and constitutional protection of First Nations jurisdiction and rights. In 2018, they were criticized, Canada was criticized for recognizing and implementing Indigenous rights framework, but doing so without consultation and free, prior, informed consent of Indigenous peoples. So this is the backdrop for understanding why things are exacerbated during the pandemic. So Thunderbird Partnership Foundation carried out a survey of First Nations communities to understand opioids and methamphetamines. So this is just one slide on the impacts from the community perspective of COVID-19. Increase in depression, anxiety, unemployment, increased substance use. So from the community perspective, they're also talking about a lack of access to their children that were in the care of child welfare systems. So from residential treatment centers, we have a national network of both adult and youth residential treatment centers that quickly had to adapt their program and their service delivery models within the pandemic because their clients all had to go home and they couldn't operate an in-person residential program. And so they continued to offer services virtually. And we have this national system that collects data from them. And so the drug use screening inventory is used as an assessment tool pre and post services. So the left side of the screen, you can't see the numbers on this, but what I want you to pay attention to is the blue portion of the bars. So the left side of the screen is prior to the pandemic up to February 2020. The right side of your screen is during the pandemic. So this is March 2020 to February or January 2021. And what we see is the blue section more significant during the pandemic. What that represents is the severity of substance use. And the severity of substance use in this time period represents increased use to 20 or more times per month during the pandemic. And so what's on the screen is alcohol, stimulants, methamphetamines, opioids, and the typical host of substances that we all want information to, and we monitor. So there was a 4 to 6% increase in severity. However, we did see First Nations communities where there was a decline in substance use during the pandemic. There's some unique characteristics about these communities. They had put up community barriers and locked down the community to promote and protect the public health restrictions and measures to keep the community safe at their borders. However, there was a concern about what that would do to people who use drugs. Would that increase the use? Would it exacerbate the harmful drugs coming into the community? But what they saw was community cohesion around that community border and the protection of their public health. So high level of compliance. The reason that happened was because there was increased support by clinicians outside the community, but also a focus on building capacity of the workforce in the community that embraced culture and Indigenous knowledge. And the support for those communities also included working across licensed, unlicensed professionals in land-based environments. It also meant that they used the virtual supports available to them, and community was engaged in regular conversations, constant conversations, to help them understand the impacts of COVID, but also to focus on alternative ways of service delivery to minimize the risks. And so as a result of community treatment centers offering virtual services, they, again, with this national database where we collect information, such as the drug use screening inventory, we also measure the impact of culture. And so treatment centers who were registering their clients in treatment in the addictions management information system administered the drug use screening inventory, but also administered the Native Wellness Assessment, Class B psychological assessment to measure the impact of culture and the outcomes of hope, belonging, meaning, and purpose, saw consistent improvement in wellness. And so the outside ring is the exit. The inside ring is the entry point. And so you can see, again, you can't see the numbers, but you can see the differences in the two circles where the outside ring represents the exit. So an improvement in wellness through virtual services. In a conversation that we had through a public health working group on mental wellness of Northern Canada, we saw consistent recommendations regarding substance use with a focus on harm reduction, building community capacity, ensuring rapid access to addictions medicine, culturally appropriate services, community-based solutions, and investments. These were the needs that were highlighted by the communities who did not see an increase of harm related to drug use during the pandemic. Where communities didn't have those supports, we can look at the determinants of health to understand what impacts the pandemic had. And so for folks who had reported food insecurity, they were 3 times more likely to be using methamphetamines on a regular and consistent basis, and reported that they preferred that methamphetamine use while not having access to food. Also, people who were experiencing homelessness were 2 more times more likely to use a methamphetamine. This might not sound really bad. It's bad enough. 3 times, 2 times, what is the magic number to get our attention around the needs of people who use drugs? What is significant about this data is this is data from rural and remote isolated communities. And so we know that most of the harm reduction programming exists in urban environments. There are communities who reported a high rate of being impacted by gangs coming into the community, overdose poisonings, and other harms to the community. Again, these are communities who did not have the structural supports to address and support people who were using drugs. Furthermore, just like the previous presenter highlighted, there are challenges to the wellness of the workforce. And so the workforce in First Nations communities, when community borders were locked down, they also, outside of that, saw the lack of capacity to meet the needs of the community. And so community workers were, had to play multiple roles and fulfill multiple responsibilities and stretch the knowledge and skills and expertise that they had to fill the needs of the community. There was a lack of access to resources, not enough personal and community experience by outsiders, external clinicians wanting to support and help the community. The colonial structures and processes that were still in place presented a significant barrier. There was also issues, again, with practicing and in service delivery, attending to the needs of your client when working from an individual perspective in the community's values are on family and community. So issues around licensing regulations, talking to family when your client is an individual, but also working with cultural practitioners in land-based programming. Differences around and understanding around personal coping and healing during the pandemic. This workforce is also, they live in the community, they're from the community, have the same intergenerational trauma oftentimes as the people that they are serving. And so that becomes an issue. Outside of the individual, though, there are systemic issues. So racism and discrimination continue to thrive during the pandemic. So what's the agenda for change? Actions for equity requires linguistic competency. Now that might sound a little odd when we're talking about these issues during the pandemic. However, our language is the foundation of our worldview. It holds the concepts of meaning that gives us evidence for supporting mental wellness. The lack of data collection and the infrastructure to support data collection in communities is a significant challenge. although I've been able to share some data with you from the National Addictions Management Information System, and through some efforts that we were able to continue during the pandemic to collect data with these communities, despite all the challenges that they were facing, we're still interested in learning more. But the broader system of data collection and capacity infrastructure needs to be further developed to broaden our evidence base. And there has to be continued collaboration through joint processes and processes that are focused on decolonization. It's not coming into the community anymore with the Band-Aid solution or the only the perspective of just a Western-based conventional evidence. It has to nurture and respect the role of Indigenous knowledge and evidence to support innovation and to meet the needs. So those holistic policy considerations, it's not just about individual. Policy has to be considerate of what impacts there are of policy for families and whole communities. And it isn't just one aspect, it's mind, body, spirit, and emotions, that whole person perspective. And so First Nations voice, recognizing First Nations experts as experts in the understanding their needs, but also for developing their solutions and building capacity within First Nations community. And when we mean capacity, it's not just the number of people, but it's also the wages of the workforce in First Nations communities are dismally less than, significantly less than their provincial counterparts. And so in a study that we did in 2010, we saw that the wages of this workforce is 47% less than their counterparts. There have been some improvements, but so has the cost of living has also increased. And so there still continues to be a significant gap in compensation for the workforce. Thank you very much.
Thank you very much, Carole. Fabulous. And I'm starting to see some things that are crosswalking between the two presentations.
Mm-hmm.
Which was going to be good for the discussion. Now I want to bring on Angela Robertson, please.
So thank you very much. And I'm hoping you can hear and see me, yes? Lovely, thank you. So I will, the benefit of going last is sometimes you get to then truncate some of what you have to say because it's been said before. So hopefully I can make up and spare in terms of time for us to have the good Q&A that we desire. So first, I think it's important for me to state that normal, so when we think about the framing for the symposia, building the new normal, is that the state of normal for the folks I prioritize in my remarks pre-pandemic, during the pandemic, held and continue to hold sites of deep structural and systemic inequality. And that has been a steady normal for many of the communities who I think we are here talking about. And that for many of us, that the pandemic has been, in fact, a fatal blow. And that also we have seen consistent repetition and deepening of those sites of inequality during the pandemic that continue to really widen the material deprivation gap, and therefore the new normal is really a new state of being. So when I think about lessons learned during this pandemic, I think it's also important to not forget that COVID is happening in the midst of an overdose epidemic, an overdose crisis, where in this province we have seen over 2,500 or almost 2,500 deaths in the last year, which is a significant increase from prior years. And we have also seen the remobilized movements against anti-Black and anti-Indigenous racism, the movements and the mobilization against Islamophobic violence, anti-Asian hate, and that these are events happening in the same moment as COVID, that, as you've heard from Carole earlier, has continued to also deepen and differentiate racialized Indigenous bodies' experience of this pandemic. So in the conversation that I've been asked to to share and reflections, I want to focus my remarks in 3 areas. So one is, I would say, it's the imperative for the collection of race-based and socio-demographic data in our systems. I would say health systems, but I would say systems broadly. Second is that we need to focus on essential workers and equitable recovery, and we'll speak to why that is important, and that we need to, what I see as embed the basic needs of Black, Indigenous, and other racialized populations in the provincial and national public policy and economic recovery and investment agenda. And those are 3 pieces that I want to pick up. Kwam spoke in the beginning about, and we heard from Carole how COVID has impacted differentially Black, Indigenous, low-income workers. For a quick summary of just running through a few bits, we have seen higher rates of COVID infection among racialized populations. This was confirmed by Chief of Public Health Officer Dr. Teresa Tam, and many public health units who started gathering some of that data. What was revealed is that 80% of COVID-19 cases have thus far occurred in people who identify as racialized, people who are not white. We have seen higher rates of hospitalization, and here in this province, Ontario, where I'm sitting, is that this is also twinned with hospitalization that's irrespective of the age, meaning that Black folks, particularly for Black populations, for Black folks who are younger, they're being hospitalized at the same rates of white folks who are older when age was identified as the risk factor increasing COVID severity, including the risk of death. And this, I think, speaks to what existed pre-pandemic, which is chronic health conditions and sites of deprivation that increased vulnerability. I think one of the things that was significant that I think we should not forget in the new normal is when resources and the resource of vaccination, when vaccination was scarce in the start of the vaccine deployment effort, and we saw the supply chain issues and challenges, is that what we saw is that communities that had the highest rates of COVID also had the lowest rates of immunization. So, and many of us who do this work and who are in the space of equity, social justice, we're not surprised by that. But I think we must remember that in the building back better, or the new normal, which is when we hear language of scarcity, is that those of us who are in the margins and those of us who are pressed up against deprivation need to be afraid, but we also need to be alert and vigilant and relentless, because it is when we hear the language of deprivation is that we know the rationing will begin and we will not be at the front of the line. And therefore we saw, as I said, when vaccine was low, is that the communities who needed them the most and who were most at risk were in fact the ones who did not get. What we also saw in the pandemic, and StatScan started collecting some new race-based data in their labor force participation, is that we saw that folks who identify as racialized Indigenous immigrants had higher rates of financial impact and higher rates of job loss during COVID than our white counterparts. So running swiftly then into 1, 2, and 3. So as I said, the number 1 being the imperative for the collection of race-based and socio-demographic data in our systems. Here in this province, the former medical officer of health, Dr. David Williams, at the start of the pandemic, in the face of the demand for data collection, said the province did not need to collect data on race and other indicators of who is being hardest hit by COVID, because as he stated, regardless of race, ethnic or other backgrounds, they're all equally important to us. And therefore, we will all get equally what should be afforded to folks in this response. We know that that wasn't true. We know that that didn't happen. But we also heard a similar echo at the same time from Public Health Agency of Canada, who similarly said the federal government had no plans to collect disaggregated data on social determinants of health as risk factors for COVID-19. And what we have seen, I think the impact of the pandemic makes those kinds of assertions not just wrong, but I would say dangerous. Dangerous because it makes the deepening inequality invisible and thus renders the experience that we, racialized folks, Indigenous folks, low-income folks experience as mere anecdotes that I think then can easily be dismissed. So I would posit that mandatory collection of race and other socio-demographic data collection must be part of the new normal, and it must be twinned with an engagement, governance, access, and protection. And many of us in this space through an Black health equity work group framed this as EGAP framework that basically envisages Black and other racialized communities gaining control over the data that is collected and being involved in the analysis and recommendations coming out of that data collection. The aim, I think, must be to use the data to improve quality by changing practices in all parts of the system. And we know that data alone will not change the social conditions. We see our US counterpart where there's a proliferation of data. They can tell you down to the footprint of a neighborhood, who is in the neighborhood, who is impacted differentially. But what we have not seen is we have not seen that data lead to conditions of change. So in the new normal, we must collect the data, but the collection of the data must be twinned with actions for improvement and change. Number two, essential workers and equitable recovery. I would say that once invisible, but we know essential, there's a group of workers who have been doing personal support, grocery store work, custodial work in healthcare settings, retail work, delivery work, who were made previously invisible, but we know essential, were now made visible and publicly deemed as essential. And they were the ones who have been putting themselves and continue to put themselves at risk, and who were early in the pandemic without all the protections of PPE, but still in the forefront of ensuring that we, those of us with means, those of us with ability, and others got access to the essential supports that they provided. I think we must be bold and suggest that there can be no equitable recovery without equity for those deemed essential during the pandemic, as we continue to need their essential services in the new normal. And that our ability to recover and return to the normal, the good new process, relies on largely these workers who are largely racialized, who comprise the group that is in the quote unquote invisible essential work category. The new normal must include, I think, increased minimum wage, preferably indexed to cost of living. And I think we must also demand the reinstatement of the wage enhancements that were given to essential workers because they were deemed essential and valuable. And that we also need to add to this provisions of benefits like sick time. What we have seen is that with vaccine rates increasing and public health measures being relaxed, is somehow now this group of once essential workers are now deemed no longer essential, and therefore some of the investments and the wage enhancements that were provided have now receded. And I think we need to lean in and push for that to shift. I think this position is bolstered by the recent awarding of David Card, the Canadian economist based in the US, the Nobel Prize for Economics for pioneering research that really showed practically, empirically, undeniably, that increasing the minimum wage does not lead to less hiring, and immigrants do not lower the rates for quote unquote native-born workers in this country. And that we must use this moment to be a catalyst for pushing for those things and demanding those things in the new normal, particularly in the midst of a new government that we have where there's an opening window. I think we also should not succumb to the demonizing and union bashing when we know that there is a unionized advantage for Black and Indigenous workers. I remember when I, as a young student seeking to work and seeking part-time work, I was always happy to find work, and mind you, I worked in a long-term care facility, to find work and hospital, to find work in organizations where there was a union. While I was not necessarily in the union as a relief, as a part-time, as a casual worker, being in a unionized workplace often meant that the hourly wages was higher. So that is the unionized advantage that I think we benefit from as Black and Indigenous workers, low-income earners. And I think we need to be cautious when we hear governments beginning to posit things that impinge on organizing and the ability for workers to organize themselves. Third, when I comment on that we need to embed basic needs for Black and Indigenous and other racialized populations in the provinces and the nation's public policy and economic recovery and investment agenda. Here, I speak specifically. I want to speak specifically about Black populations, but knowing that it has implications for other populations, including other racialized populations and Indigenous peoples. I believe when we push back against government's election cycle funding approaches, and Carole mentioned that, which are oftentimes short-term, small, sometimes maybe larger multi-year with a pilot, but always asking for us to be innovative. And the innovation to respond to, I think, income disparity is higher wages. How much more innovative than that can you get? But I think we must push for plans and strategies and actions that lift up what I see, and many of us here in this province, a small huddle group of us are working on a Black health plan that is focused on sustained health equity and structural changes for Black populations. Plans and approaches that embed basic needs improvement strategies for Black, Indigenous, racialized populations. And I think this makes investments in things like affordable housing, food justice, childcare, healthcare, transportation industry and infrastructure, labor market participation, income support, education, justice and policing. If we bring an equity and anti-Black racism lens to the recovery efforts, to the national public policy efforts, then what we're saying is that all of these things are really anti-Black racism, anti-Indigenous racism strategies, because affordable housing and the need for affordable housing to respond to the homelessness crisis, I believe, is an anti-Black racism strategy. It is an anti-Indigenous racism strategy when we know that for folks who self-identify as homeless, over 30% self-identify who are Black and self-identify as Indigenous. And I think I borrow from Kwame here when I say that we need to, quote unquote, hardwire this approach into recovery back to normal so that we can make tangible changes on the structural and systemic sites of deprivation. Because I do not believe that we can have and we can use this moment will be used. Because I think that if we don't do this, then we will not get, what we will get is the optics of change, but not the substance of equitable change for Black, Indigenous, racialized, and other marginalized populations. So I will just turn to, I think, Wellesley team to just bring up one slide that I just want to share in a final comment before we move to the Q&A, is I shared this particular slide, which comes from a vaccine clinic that we held in a predominantly low-income, highly racialized, large number of Black populations, Black people living in this area, the Jane Finch area here in Toronto. And this was a vaccine clinic held at a time when vaccine was scarce, and also at a time when the talk was, because vaccine is scarce, then I think there was also an inference that we would not bring vaccine to communities where there is perceived high rates of hesitancy, because basically folks would not come. This was a weekend event, April 17th and 18th in 2021, and this became one of the largest pop-up vaccine sites that was held in the first rollout of the vaccine campaign in this province. And what you see here are groups of Black women thawing the vaccine. And I see this as an image of how the folks who have been pressed up against sites of deprivation, sites of marginalization, are ready and committed to bring care to their communities. What we don't have is we don't have the resource to enable that and to enact that and to bring that into being. But if we have the resource, is that folks, I think this is, hearkening back to Carole's comment, is that the community and the people in community are committed to delivering and ensuring that the community get the care it needs. So therefore, what this moment of this new normal, I think, calls for is enabling the community to get the resources that they need to bring that care to community. So these Black women were trusted as well to be the thaws, to thaw the vaccine. These are precious vials in a type of scarcity. If it breaks, that's 10 less people who would have this life-saving and protective factor of vaccines. And again, this brings the issue of trust, is that we have not been trusted to bring care to community, because somehow we have also not been trusted to be the executors of strategy for the benefit of communities. And I think in the new normal, we need to have the resource and we need to be trusted that we have the capacity and the ability to bring care and to bring good care and to enable equity in our communities. So thank you, and looking forward to the Q&A. Thanks.
Brilliant, so lovely. So can we get all of the panelists back now? So all into the same view. Get everybody right. Wonderful. And are we going to be in gallery view now? Spectacular. So some wonderful presentations. Really like, all slightly different, but with some significant commonalities. Now, I have 150 different questions I would like to ask, but we've got a number of questions that have come through, and I'm being sent them by my controller. I'm being controlled by our communications department. The first question from the audience. I appreciate how folks are noting that we still need a number of, we are still in a number of pandemics, but while the rest of the world moves on, many of us are still in survival. So what is the new normal? And I'm going to go to Carole and Carole, because I think this question came in before Angela very clearly indicated what she thought the new normal should be from her perspective. So Carole and Carole.
Shall we still follow the same speaking order?
No, just jump in.
Okay. Yeah, I challenge, and along with others, certainly I heard that in Angela's talk, what we mean by normal. And so we have to raise the awareness of the current inequity that exists, the racism that exists, and the conditions that facilitate this, and some of those being the jurisdictional divides and lack of engagement in policy development. So if that's our normal and we have no new resources to address those gaps during the pandemic, then how do we sustain ourselves following the pandemic? Does the new normal mean going back to the conditions that we've always lived with? Or does it mean opportunity to support the innovations? For example, I talked about virtual treatment services. Seems fairly simple. It's working. We're doing an evaluation. We're seeing the collection of data to help demonstrate the efficacy of those services, but no promise. So where does that promise come from? Province will say, well, that's federal government responsibility. Federal government will say, well, provinces have responsibility for mental health. Where are they in this conversation? And we're back in the ping pong. That's a continuation of the normal. The new normal, I was jumping up and down and high-fiving Angela for all of her comments. We have lots of strengths. The question is, how do we get people engaged to respond? And it's not just on Black and Indigenous people. We have to have partnerships, and that's what we're talking about in the context of reconciliation. It's not just Indigenous people who have to engage in reconciliation. It's all of Canada who have a role to play in reconciliation. So yeah, what is normal? Continuation of the old and the same, or realizing that was there, people just didn't talk about it. Now there's more awareness, and we can use that awareness to create change.
Okay, perfect. And Carole, just to put a slightly different twist on the same question, at the end, you gave a very clear set of ideas and how to move forward, Dr. Estabrooks. And that was clear, but right early on in your presentation, you intimated that actually we needed a change in culture, because, you know, how did we get to a point, how did we get to a culture where we were so neglectful of long-term care and neglectful of elders that we were happy to sacrifice them in the pandemic? So what can you say about the new normal and how culture needs to change in order to change the way we think about older people?
Thank you. I'll start by saying there's a tremendous pressure to go back to the old normal in the sector I work in. It's palpable. And the standard superficial responses, we can't afford it in my sector. But that is really a false argument because it doesn't address where we need to go and why we don't want to go there. So where we need to go, and about inequities, like there's an added layer in the residential long-term care sector. All the vulnerabilities are there, but we have organically, one's voice is removed as the disease of dementia progresses. So you have no more voice. You are so vulnerable to the goodwill of strangers. And what's left of goodwill, if there's even any family left, because these are people whose average age is 85. So families are distant, they're dispersed, they may be estranged, et cetera, et cetera. So this group is so vulnerable. We have to advocate for them, which is really kind of advocating for ourselves, because there's only one trajectory in life, and that's aging. And then that's compounded by a workforce that's been silenced for many of the reasons that Angela and Carole have spoken. It's a highly racialized workforce. It's a vulnerable workforce. It's older women. It's, et cetera, et cetera, et cetera. So how are we going to approach this? Nobody I've talked to wants to talk about the root causes of why it was so catastrophic in long-term care, because they're hard And we don't think in polite Canadian society, we may be able to admit possibly that we have, well, not really doing that well. So it's difficult enough to talk about institutionalized racism, but ageism, it is also, we don't like to talk about the fact that we have treated our old adults like garbage that we can throw away in an institution and lock the door and go away. And I don't think Canadians as individuals are malevolent. I think what happens is it's more convenient to enact a kind of benign neglect. We close the door and tell ourselves, oh, it'll be okay. They'll be taken care of well there. And that's not served us well. So to change culture, we have to address our own feelings, our own beliefs, and our own values about aging, about death, and about cognitive and intellectual disability, which is where the dementia comes in. And we have to address our core values around sexism, and we do not like to talk about that in polite company. And our attitudes about caregiving as women's work, domestic work, which has always been devalued and undervalued for all sorts of historical reasons. I don't know how you just fix that, but if we don't get at those root causes, we will help. Well, we've already gone back to the old normal in lots of cases. We've removed the one worksite policies because we didn't have enough supply to manage it. We have removed the incentives financially. We haven't moved to unionization where there isn't none. We haven't changed the structure of ownership in terms of private for-profit and public not-for-profit, or regulated the private for-profit sector, which can be done. It's difficult, but it can be done. So we're already slipping back. And now I think what's going to happen, what could happen in long-term care if we aren't vigilant, is a death by incrementalism.
Okay.
So we will raise the hours, which are now at about 3.3 in the country. 20 years ago, they should have been 4.1. They probably should be 5.7 or 6 right now. We'll raise them by fractions that aren't going to make the kind of substantial difference they need. And that's just one of many things. So the old normal being the new normal is one of the things I think that terrifies us the most in this sector, where so many things come together in terms of what's out in the community.
Okay, so I think we've got a few questions. So I'm going to come through. I'm going to try and make sure we rattle through the questions and get your best crisp answers. And some of them coming from the audience are a bit challenging. So you're not going to be able to do all of them. So if we can keep it focused. So question 2, we are so used to being at the end of the line. So we mobilize on our own and still we're not listened to. How do we get policymakers and decision makers to actually operationalize high-level equity frameworks rather than perpetuating the current racial inequities? Using actual evidence coupled with lived experience does not seem to move policy. Angela and Carole, Hopkins.
I saw that question. I thought, "Woo, that's a thesis coming on." But taking a go at it, I'll just use maybe the example of some of the approaches that some of us have taken in a small cluster in Ontario. So I come from the, as a, feminist collective, which is, all you need is, you need 2 women at a kitchen table to mobilize a strategy, and many things are possible. And I think my approach, and the approach that I kind of recommend, is one where, even if it is a small group, is that the site of intervention that we seek is the site where there are the system leaders who are making decisions and advancing structural and policy changes, and pull them into a conversation. So oftentimes we end up being called to a meeting. I do the reverse. I love to call a meeting and have other folks come to that meeting, because it means that what folks are coming to is an agenda that we have set, that we are saying, this is the agenda we now want to become your agenda. So one is just shifting that orientation. Oftentimes we position to be asked to be invited in. And for me, I think this moment calls for and opens a window of a little bit of the reverse. That I think then enables, that I think then also positions, as I said in my third point, is about getting the structural systemic strategies and as the sites of changes that we want embedded in the public policy agenda that is moving forward. And there will be pushback because there's oftentimes the attempt to then assuage, acquiesce, sideline by giving you small pockets of funding. And sometimes it's very attractive when you're without. Yeah. And we get seduced by the 24 million over a year, over 2 years for something. But that really is only about a particular program. It's not about the system around us. So every cycle we come back to those pots of 24 million or 12 million. And I'm saying, no, I don't want your money. I want you to hold the money and I want the change. And you have accountability for delivering that change to me. So that's kind of just an orientation that I've come to, in addition to taking to the streets, of course, because I think you need the beginning. I think you need the 2 sandwiches. I think you need the streets, and I think you need those, what I call provisional alliances table to embed strategies in national and public interest policies.
Perfect. Carole Hopkins.
Wow, that was well said, Angela. I'm not sure what I can add on to that, but I'll try. I think while I was listening to your response that I wholeheartedly champion and believe in as well, is that we have an issue, a problem where we have internalized oppression and we have internalized colonization. And so we're afraid to believe that change is possible. And so we need those champions to facilitate conversations that get at the fear, get at the false beliefs that it's not possible. I often hear, First Nations governments and workforces talk about the proposals that they wrote that didn't get funded. And in the response, it was, we don't have enough data. We need to have the data to demonstrate the need. And so the data is produced, but it's not the right kind of data. It's not valued. Then there's the worldview challenges when we put forward this framework that says culture is the foundation. We have to use our own knowledge and our own culture to make the difference. But there's this space of ambiguity, and we're not comfortable living in that space of ambiguity where the expert says, I don't really understand, but I want to understand. And First Nations say, well, I don't really trust you with this sacred, precious knowledge that you're going to really understand and use it to support our needs. And so we're in this space of fear, of mistrust, and a history that demonstrates it's not just made up. Over and over again, we see these challenges before us. And so in those spaces, it is the courage, it is the tenacity, but it's also having those partners alongside and championing your voice, helping you to articulate, whether it's Black people, Indigenous people, to articulate those policy objectives, to articulate the need, facilitating, let's massage the message this way. Let's invite this group to a conversation. So the supporters, the allies, they're absolutely necessary for facilitating a way forward that champions populations of need, Black people, Indigenous people, workforces that are marginalized, forgotten about, the population that they serve, to support and to work alongside.
So I'm going to try and get through, because that's fabulous, and I think we're moving here nicely. And I'm going to try and get a couple of more questions in, but we've only got 5 minutes left. So the first one, which is, how can we expose the contradictions in policy and practice in the new normal out in the public? So how can we expose the contradictions in policy and practice in the new normal out in the public? People saying there's a new normal when it's the old normal, and the problems in the new normal. What can we do about exposing that gap between policy and practice? Everybody can jump in.
Well, one medium is social media. It has quite a presence and has raised the profile of racism of Indigenous populations. So unfortunately, the experience of Joyce Echaquan in a Quebec hospital called attention to the racism experienced by Indigenous people in the healthcare system in Canada. And it was through social media. Social media raised the attention of the Innu populations that had high rates of suicide, and there was no response to that. So when they exposed that story nationally, it went worldwide. There was a response from the federal government. But I mean, it shouldn't be to that extent where we're pushing hard, but it's necessary. And so I'll just say social media is one way to expose those discrepancies and gaps and contradictions.
So in the modern world, social media and, as Andrew was saying, getting out on the streets are a similar thing, can be similar things, or at least complementary things, yeah? Okay, Carole Estabrooks, I can see that you've unmuted.
Well, the social media comment's interesting because we've worked locally. Well, we have a national program, but we've worked quite aggressively to create a social media presence. And it's, we hit a ceiling, we did really well, and then we hit a ceiling and we just can't move beyond it. And I think part of it is that, and we look at the profile of our users, and they tend to be white women between 55 and 70. And we have tried everything to penetrate other groups. But the social media work we're trying to do is on behalf of others. And it's very hard to mobilize the same cohorts out in the community. And so it's a conundrum to me how to maximize social media, because we have not had much success at penetrating younger populations or different demographic profiles. So I understand fully how powerful social media can be, but when you're always advocating on behalf of a group, the people that socially we don't think is that important. I mean, we don't, or we wouldn't do what we do. Mm-hmm. I'm curious about how, if that's actually the right avenue here. The media, the regular media, has been more effective, I think, in the areas that I work in, and finding people whose lives have been personally touched. But of course, the people in power don't often encounter, I mean, and others know this better than I do, but it's better for us in that way. They all have moms and dads. And sometimes, despite their wealth and their connections and their best efforts, they can't make it right. And so that's one of the strategies, I think, in working with older adults that we can find it. Because if you can find a minister of health or a prime minister or a deputy or a senior civil servant or a well-known media person who's been touched painfully by the problems in this part of the system, it's easier to make some things loose. The problem is that that's one person in one sphere. Mm-hmm. You know, it takes a lot of them together I don't know the solutions, but we keep trying different strategies.
So Angela, we're right up against the end of it. So I just wanted to give you the last word before we start to wind up.
And I agree with in terms of Carole and Carole's comment about in terms of social media, but also some of social media's limitation, the possibilities, because I think social media has certainly enabled a kind of what we call a kind of a democratizing of communications in a way that I think does enable folks to put stories out and to agitate and push. So I think that's one. It doesn't work for all of the strategies. So I think the media, the main quote unquote mainstream media, is another sphere. And I think many of us who did the push on the race-based data collection use that as the medium, and that was quite effective. And then I think the other piece that I think it's also about twinning all, because I think the other piece for me is also about calling the question. So it's being also very direct and directive about the question that we're seeking to call, or the policy contradiction that we're wanting to cite and lift up. And for me, it's always not just calling the question, but having a solution. And this I've learned from you, Kwame, is, if you call the question and if you cite the problem, is also cite and bring forward solutions. Because oftentimes the assumption we make is that the people who are doing the planning have and know the solution. And sometimes they don't, or the solution they have, it's the wrong solution that will certainly not produce what we need. So for me, it's always doing that, but bringing a solution to the table, or solutions and strategies to the table. Thank you.
Thank you very much. We're right at the end. We're at the end of today's event. It's gone quickly, brilliant and wonderfully engaging discussions from different areas, but coming to the same question of what the new normal. Really love the fact that we cited problems, but we also cited solutions, but also that those solutions are fundamental, ask for fundamental change. And of course, we need fundamental change. I'd really like to thank Carole, Angela, and Carole. Wonderful presentations, wonderfully engaging presentations, and loved it at the end when we started getting in to the what next. I really love and thank everybody who's attended and virtually, and you probably know that we had over 350 people sign up, and a couple of hundred people attended, and then we'll often on top of that, I'm sure people will be looking for the video. A reminder that our next panel is on Wednesday, the 27th of October, and it's not too late to register. And we'll be discussing housing and health at that time in the new normal. And hope to see you there. Now, as soon as we finish here, because we're evidence-based, there'll be a short survey that will appear on your screen in your browser. And we'd really appreciate your feedback on today's event so that we can continue to improve. So thank you, everybody. Stay safe and goodbye.